Welcome to the funnel effect.
Today we're diving deep into something that feels like a real sea change in interventional cardiology. Our main source is a state-of-the-art review, Ultra-Low Contrast PCI from JCC. Cardiovascular Interventions, Volume 18, Number 4, published in 2025.
Hi.
And the author list is pretty extensive, gives you an idea of the weight behind this. We've got Asad Shabir, Ziad Ali, Giuseppe Coletti, Darius Dudek, Roberto Garbo, Farrell Helig, Jeffrey Moses, Abdul Mozid, Suno Nakamura, Bilal Patel, Gabor Tooth, Nadawat Wang Praparut, Nevis Gonzalo, and Javier Escond. Quite the lineup.
Wow. Yeah, that's a serious list. It definitely signals this isn't just a minor tweak. So we're talking about PCI, percutaneous coronary intervention. And historically, it's always leaned really heavily on using that iodinated contrast dye.
Absolutely. It's always been the way we see things.
Yeah.
You'd inject the dye, and it lights up the coronary arteries on the X-ray. It's how you plan the procedure, how you guide your wires and balloons and stents, and, well, how you check your work at the end. It's sort of the visual bedrock.
The visual bedrock. I like that. But that bedrock, it's starting to show some cracks, right? Especially for certain patients.
Exactly. That complete reliance on contrast.
Mm.
Well, it's becoming a major vulnerability. The kind of patients we're treating now, that old standard approach, it actually introduces some pretty significant risks.
Okay, so contrast gives us the picture, but it also carries risk, kidney risk being the big one, I imagine.
That's the main concern, yes.
So let's unpack this shift. Our goal today really is to explain why that contrast dependency is becoming problematic, especially for these high-risk folks. And maybe more importantly, show how this newer structured approach, ultra-low contrast PCI or ULC PCI, is kind of flipping the script.
Right. It's about moving away from just looking at shadows on an angiogram and instead using objective tools like advanced imaging and physiology to guide the procedure.
So it's about improving safety, cutting down that kidney risk, but also improving the quality of the intervention itself, making it more precise.
Precisely. Better safety and better quality. For you listening, this is really key to understanding where modern interventional cardiology is heading. It's a shortcut, if you will,
Right.
to grasping how we're moving beyond just the visual and towards, well, precision PCI. Making complex procedures safer and more effective, even for patients who might have been considered too high risk before.
Okay, so let's start with the why. Why this big push for contrast hygiene, as the authors call it? Is it just because we have cool new tech, or is it really driven by the patients walking into the cath lab today?
Oh, it's definitely driven by the patients. There's been a huge demographic shift over, say, the last decade or so.
Uh-huh.
We're routinely seeing older patients, people who often have a lot of other health issues going on, diabetes, high blood pressure, maybe some level of chronic kidney disease already.
Right.
And on top of that, the coronary disease itself tends to be more complex. We're talking about really tough calcified blockages, people who've had bypass surgery or stents before, challenging situations that just inherently take more time, more complex maneuvers in the lab.
So more fragile patients needing longer, trickier procedures. And I guess instinctively that means using more contrast dye to see what you're doing at each step.
That's exactly the problem. More complexity often meant more contrast injections. Multiple views, checking progress, final result. It all adds up. And that directly increases the risk of complications.
And the main complication we're worried about here is kidney damage.
Yes, specifically contrast-associated acute kidney injury, or CAAKI. It's often temporary, thankfully, but it's still a major hit to the patient. It increases morbidity significantly.
Okay, let's nail down the definition. How do they actually measure CAAKI? What are the numbers?
So the standard definition they use is a measurable drop in kidney function after the contrast. So typically, it's an increase in the serum creatinine level of at least 0.5 milligrams per deciliter.
Okay.
Or, alternatively, you can look for a 25% or greater increase from whatever the patient's baseline creatinine was before the procedure. And you typically check for this change about 48 to 72 hours afterwards.
Got it. 0.5 absolute increase or 25% relative increase. And how common is this? What are the real-world consequences?
Well, the risk varies. In really straightforward, low-risk PCI cases, it's actually quite low, maybe less than 2.5%.
Okay, that sounds manageable.
But in those high-risk patients we were just talking about, the older, sicker ones, complex procedures, that rate can jump up dramatically. We're talking 15%, maybe even up to 20% in some groups.
Wow, 1 in 5. That's really high.
It is. And it's not just a blip on a lab test. CAAKI is linked to worse outcomes across the board, more complications, higher mortality rates down the line, definitely longer hospital stays, and a tougher recovery overall. For someone already vulnerable, an AKI can be the thing that tips them into needing dialysis permanently or worsens their heart failure. It's a serious event.
Absolutely unacceptable risk level for that group. So if the risk is tied directly to the amount of contract, there must be a way to quantify a safer limit, right?
Yeah.
What's the key metric for this ULC-PCI strategy?
Yes, and this is probably the single most important concept to take away from ULC-PCI. It's all about the ratio between the contrast volume, or CV, used in the procedure measured in milliliters, and the patient's estimated glomerular filtration rate, or eGFR, which is a measure of kidney function, in milliliters per minute.
Okay, CV over eGFR.
Exactly, and the magic number, the target based on lots of clinical data for optimal safety, is keeping that ratio less than 1. CV divided by eGFR should be less than 1.
Less than 1. So just to make that concrete, if a patient has an eGFR of, say, 40 LMN,
Then the absolute maximum contrast volume you should aim to use for the entire procedure is less than 40 milliliters,
that's incredibly clear. It gives operators a really precise target. Why is that ratio so powerful?
because it personalizes the risk. It directly links the dose of the toxin, the contrast, to the individual patient's ability to clear it via their kidney function.
Yeah.
Keeping it below 1 means you're likely not overwhelming the kidney's capacity, minimizing the chance of injury. It replaces that sort of gut feeling of, oh, maybe I've used too much dye, with a hard objective number.
Makes perfect sense. Now, obviously, this is crucial for patients who already have chronic kidney disease, CKD. But you mentioned earlier, and the paper stresses, that ULC-PCI isn't just for CKD patients. Where else is this contrast hygiene so important?
It's critical in basically any situation that promises to be technically demanding or lengthy. Think about heavily calcified arteries. You need more imaging, maybe atherectomy,
Right.
chronic total occlusions, CTOs. These can take hours, and multiple contrast runs traditionally. Complex bifurcations, where you're treating a main vessel and a side branch, or treating multiple vessels in one go. All of these inherently risk high contrast doses, even if the patient starts with perfectly normal kidneys. ULC-PCI protects them proactively.
Okay, that broadens the scope considerably. And this leads to something you touched on, this idea of renalism. That sounds like the fear of kidney injury was actually leading to, well, bad decisions.
That's exactly what renalism describes. It's this historical pattern where clinicians were so worried about causing CAKI in patients with known kidney problems that they became overly conservative. They might avoid necessary diagnostic tests, or perhaps more importantly, shy away from doing revascularization procedures, like BCI, even when strongly indicated.
So the fear of hurting the kidneys meant they might not treat the heart disease properly, leading to worse outcomes for the very patients needing help most.
Precisely. It resulted in what the authors call systematic undertreatment. CKD patients often receive fewer diagnostic angiograms, fewer attempts at opening blocked arteries, and ultimately they had worse long-term clinical results compared to similar patients without kidney disease. It was a terrible paradox.
Wow.
ULC-PCI really helps dismantle that. By offering this structured, safe pathway, sticking to that CV-GFR ratio under 1:1, we can now confidently and safely treat complex heart disease even in these high-risk patients.
Yeah.
It allows us to be appropriately aggressive, aiming for complete revascularization, maybe even in one session, without putting the kidneys in undue danger.
So ULC-PCI isn't just about making the procedure safer, it's actually enabling better care. It lets us treat patients effectively who might have been undertreated before, purely because of the procedural risks associated with contrast. It's moving from fear to precision.
That's a great way to put it, fear to precision. Okay, so if we're going to intentionally limit our main visual tool, the contrast, then meticulous planning becomes absolutely paramount. The success of ULC-PCI really hinges on squeezing every bit of useful information out before the patient even gets to the cath lab table.
Right, you need to know the battlefield intimately if you're going in with limited visibility. Like prepping for a flight, you need the flight plan locked down. Where does that planning start?
It starts with homework. You absolutely have to review any prior imaging the patient might have had. Old angiograms, functional tests, look at them closely.
What are you looking for specifically?
Details. How twisty are the vessels? Where's the calcium and how bad is it? Are there tricky side branches near the blockage? If there's a chronic total occlusion to CTO, what does the entry and exit look like? Every little anatomical clue helps build a mental map.
And you mentioned functional assessments. Can we get that kind of information from old angiograms too, using something like functional coronary angiography, FCA?
Yes, FCA is a really valuable tool here. It uses computational fluid dynamics to analyze those old angiograms and estimate the physiological impact of the narrowings. It helps confirm which blockages are actually causing ischemia, the lack of blood flow.
So it tells you which lesions are functionally important to treat.
Exactly. And beyond that, it can give you a good estimate of the lesion length and even let you simulate the PCI strategy virtually. For instance, does this look like a short focal problem needing one stent, or is it long and diffuse, requiring a different approach? Getting this info up front means fewer, let's just take a look, contrast injections during the actual procedure. You already have a device plan.
Okay, planning with old data is step one. What about getting new, detailed anatomical information beforehand? CTCA computed tomographic coronary angiography comes to mind. How does that fit in, especially since it uses contrast itself?
Right, CTCA can be incredibly helpful for planning complex cases. It gives you this beautiful 3D view. You can see the aortic root shape where exactly the coronary arteries take off. And crucially, it gives a fantastic map of calcification, where it is, how thick, circumferential, or eccentric.
And knowing the calcium burden helps you choose the right tools, like rotational atherectomy.
Absolutely. It helps you anticipate needing plaque modification tools, plan the best X-ray angles to see the lesion well. It really streamlines the planning.
But there's the catch. The CT scan itself uses contrast, so isn't there a risk you blow the contrast budget before you even start the PCI? Where's the line?
That's the critical point. You have to be extremely cautious using CTCA in patients with advanced CKD, particularly stage IV or V, those with severely reduced kidney function. Standard CTCA protocols often use a pretty hefty dose of contrast, easily enough to exceed that crucial CVG-FR ratio of less than 1 all by itself.
So for those really high-risk kidney patients, a pre-procedure CTCA might actually be more harmful than just going straight to the cath lab.
It often is. For those patients, it might be better to get the diagnostic information during the invasive procedure itself, where you can use tiny targeted contrast injections, keeping the total volume much lower. Or, if CTCA is deemed absolutely essential, maybe for complex bypass graft anatomy, that's hard to see. Otherwise, it must be done using specific ultra-low dose contrast protocols. Standard CTCA is generally a no-go for stage IVV CKD in this context.
Okay, careful patient selection for pre-procedure CTCA. Got it. So, anatomy mapped, physiology understood. Next up is prepping the patient biologically. Renal protection, hydration. We know hydration is generally good, but you flagged this needs to be careful in advanced CKD.
Very careful. Nuanced is the word. Patients with stages 4 and VCKD often have underlying heart failure issues, meaning their hearts might already be struggling with fluid overload. They often have high filling pressures.
Right.
So just blindly pumping in IV fluids according to a standard protocol can actually be dangerous.
Why? What's the risk of too much fluid in this group?
You risk pushing them into acute vascular congestion, basically overwhelming their heart's ability to handle the extra volume, which can lead to flash pulmonary edema fluid in the lungs. Not good. The aim is kidney protection, not triggering a cardiac crisis.
So hydration needs to be targeted, not one size fits all. What's the specific recommendation then?
For patients with stage 3 CKD or better kidney function, the standard Poseidon protocol, which guides hydration based on risk factors, is usually fine. But for those highest risk patients, stages 4 and V, the recommendation is a 1/2 Poseidon protocol, essentially cutting the recommended fluid rate in half to account for their likely reduced volume tolerance.
Half-dose hydration for the sickest kidneys? And how do you monitor this during the procedure? Make sure you're not overdoing it.
Ideally, you'd guide it using measurements like the left ventricular end diastolic pressure, or LVEDP, if you can get that easily, or at least monitor their clinical status, maybe pulmonary wedge pressures, very carefully. The key is to hydrate adequately for kidney perfusion, but constantly assess their volume status to avoid overload. Check pressures before, during, and importantly after the procedure too, as things can change.
That's really personalized fluid management.
Mm-hmm.
Okay, last point on pre-procedure prep. Are there any magic pills? Any drugs we can give beforehand to protect the kidneys from contrast? Things like sodium bicarbonate or N-acetylcysteine used to be talked about.
Yeah, they were. But the current evidence is pretty clear on this, and the review states it plainly. There's no convincing data to support using sodium bicarbonate or N-acetylcysteine, NAC, for preventing CA-AKI.
So scratch those off the list.
Pretty much. The focus really has to be on the procedural techniques, minimizing the contrast volume itself, using ULC PCI strategies, and optimizing that targeted hydration. It's about mechanics and careful fluid balance, not pharmacology.
All right, planning done, patient prepped. We're heading into the cath lab. This is where the rubber meets the road, shifting from relying on contrast seeing to objective measuring. Let's talk practicalities. Starting with how you get access to the arteries, radial versus femoral.
Yeah, access choice matters. Generally for ULC PCI, radial access through the wrist is preferred. Why? Well, multiple studies show it leads to less bleeding compared to femoral access in the groin.
Okay, less bleeding sounds good. How does that link to kidney protection?
Less bleeding means less risk of hemodynamic instability, less need for transfusions, all things that can indirectly stress the kidneys. So lower bleeding risk seems to translate to a lower risk of CKA-KI, particularly these CKD patients.
Makes sense. But you mentioned a caveat before about radial access.
Yes, a really important one for patient longevity.
Uh,
If you have a patient with advanced CKD who is likely going to need dialysis in the future,
uh-huh.
you need to preserve those radial arteries. They're prime real estate for creating an AV fistula, which is the best long-term dialysis access. So if someone's already running out of access options, you might have to choose femoral access for the heart procedure, even with its slightly higher bleeding risk, to save that radial artery for their future dialysis needs. It's a crucial judgment call.
A tough trade-off. Protecting future lifeline access. Okay, access sorted. Now let's get into the nitty-gritty, the small things that save those precious milliliters of contrast. What does good contrast hygiene look like, minute to minute?
It's about being constantly mindful. Simple things like using abbreviated angiographic runs, just the essential views, maybe lowering the frame rate slightly, using wider X-ray fields so you don't have to pan the camera around, because each pan usually needs a little test puff of contrast.
Ah, okay. Avoid panning.
Yeah. And simple stuff like making sure you aspirate any leftover contrast at a guide catheter before you flush it or inject medications. Don't just push waste contrast into the patient.
And for those patients with really, really poor kidney function GFR below 15, you can actually dilute the contrast.
Absolutely. That's a key trick. You mix a contrast 1-to-1 with saline, it has the iodine load right there. Now, diluted contrast is less dense, so you might need to bump the X-ray frame rate up a bit to see it well, but the overall iodine saving is significant. And using automated contrast injectors helps too. They deliver very precise, small volumes compared to hand injecting.
Okay, every drop counts. Now, getting the guide catheter into the coronary artery opening, the ostium, normally you give a little puff of contrast, right? Maybe 3, 4, 5 milliliters just to confirm you're in. How do you do that without contrast?
Good question. First, you choose your guide catheter shape carefully, maybe less aggressive shapes. And definitely avoid guides with side holes. They just waste contrast out into the aorta.
Right.
For confirming you're properly seated, there's a neat physiological trick. A quick, forceful injection of about 10 millimillimeters of saline into the ostium can actually cause tiny temporary changes on the ECG, little ST or T wave flickers.
Really? Saline injection shows up on the ECG.
If you're properly engaged, yes, it momentarily changes the local environment. That confirms deep engagement. Also, simply advancing the guide wire down the artery confirms you're intubated. You see the wire silhouette move down the vessel path on the fluoro screen. No contrast needed for that confirmation.
Using physiology and the wire itself. Clever.
Yeah.
Okay, catheter's in. Now you need to navigate the wire, especially through complex blockages or around bends. How do you do that precisely without roadmap contrast shots?
This is where a technique called the metallic coronary skeleton comes in. It's fundamental for low contrast work.
Metallic skeleton sounds cool. What is it?
You strategically place additional guide wires, usually soft, floppy ones, into key anatomical locations around the lesion you're treating. Maybe into a major side branch just before the blockage, or maybe marking the distal end of a long CTO. These extra wires act like non-contrast landmarks. They create a metallic map right there on the fluoroscopy screen, helping you orient your main working wire and devices much more accurately without needing contrast puffs for location checks.
Using the tools themselves to build the map. I like it. And then there's software helpers too, like dynamic coronary roadmap, DCR.
Yes. DCR is a really sophisticated example. Systems like the one from Philips Medical take an initial brief contrast injection to create a reference image of the artery. Then the software overlays this map onto the live fluoro screen.
Okay.
But the clever part is, it dynamically adjusts for the patient's breathing and heartbeat. So the artery map stays relatively still on the screen, even as the patient moves. It lets the operator navigate wires and balloons, almost as if they had a continuous contrast injection running, but without the dye. The DCR4 contrast trial showed it really does significantly cut down contrast use, especially in complex cases.
Okay, those are great tools. But now let's get to what the paper calls the cornerstone technologies, intravascular imaging and physiology. Let's start with IVUS intravascular ultrasound. How does IVUS directly replace the need for contrast?
IVUS is, well, indispensable in this setting. Remember, a standard angiogram just shows you a 2D shadow of the blood-filled lumen. It tells you almost nothing about the vessel wall itself, what the plaque is made of, or the true size of the vessel.
Right, it's just a silhouette.
IVUS gives you a high-resolution, cross-sectional ultrasound image from inside the artery. You can see the plaque. Is it hard calcium, soft lipid, fibrous tissue? You get precise measurements of the lesion length, and critically, the actual vessel diameter. These objective measurements are what you need to choose the right size stent and length. It replaces guessing based on the angiogram.
So no more contrast puffs just to estimate vessel size or find the shoulders of the lesion. Do we have hard numbers on how much contrast IVUS saves?
We do. The Mozart study is a key one here. It compared IVUS-guided PCI to standard angiography-guided PCI. The results were striking. The average contrast volume plummeted from about 64.5 millimillar in the angio group down to just 20 millimillar in the IVUS group.
Wow, that's less than a third.
Exactly, a massive reduction, simply by using IVUS for the critical decision-making steps like sizing.
And this benefit isn't just about saving contrast, right? It translates to better outcomes, especially for these CKD patients. You mentioned the Ultimate trial.
That's right. Ultimate showed that using IVUS guidance in patients with advanced CKD didn't just cut contrast use and lower the rates of CKI, but it also led to better long-term results specifically, less chance of the treated vessel failing later on. So IVUS delivers on both safety and quality. In fact, there are studies showing that completely zero-contrast PCI, guided solely by IVUS, is safe and gives excellent, durable results in high-risk kidney patients. It truly can replace the angiogram as the main guide.
Okay, IBUS gives us the detailed structural picture. Now the other pillar. Physiological guidance using FFR or NHPRs, fractional flow reserve, or non-hyperemic pressure ratios. Why is measuring pressure inside the artery so vital in a low-contrast approach?
Because physiology shifts the question from what does the blockage look like to what does the blockage actually do?
Function over form.
Precisely. Wire-based physiology objectively tells you which narrowings are actually limiting blood flow enough to cause ischemia. And it can pinpoint where the pressure drop is happening. Is it one tight spot or the disease spread out? Having that objective functional data means you're less tempted to inject contrast just because a stenosis looks maybe 70% on the angiogram, if it's significant or not based on the pressure reading.
Let's quickly clarify NHPRs. FFR needs that drug adenosine to stress the heart, right? Which can add time and complexity. What are NHPRs, like IFR or RFR?
NHPR's non-hyperemic pressure ratios are resting indices. They measure the pressure gradient across the stenosis while the heart is just beating normally at rest. No need for adenosine.
Okay.
In a low contrast setting, especially if the patient is unstable or the procedure is long, being able to get a quick, reliable, functional assessment without inducing hyperemia is a big advantage. So resting indices like IFR, instantaneous wave-free ratio, or RFR, resting full cycle ratio, are often preferred in ULC PCI for efficiency and safety.
Makes sense. And the real cutting edge seems to be combining this pressure data with the wire's position on the X-ray using core registration. Can you explain how a system like SyncVision uses this? It sounds like GPS for the coronary artery.
It's a bit like that, yeah. Core registration fuses the data streams. As you pull the pressure sensing guide wire back through the artery, the system continuously records the pressure readings and tracks the wire's position on the live fluoroscopy image.
Okay.
So what the operator sees on their screen is the pressure graph showing exactly where the pressure drops, directly overlaid onto the image of the wire sitting in the artery. Remember, the wire silhouette is our non-contrast angiogram here.
Do you see the pressure drop mapped precisely onto the physical location in the vessel?
Exactly. This lets you pinpoint the start and end of the functionally significant lesion with incredible accuracy. You can measure the exact length needed for the stent based on physiology, not just visual guesswork. And the really powerful part is virtual stenting. You can digitally place a stent of a chosen length and diameter on the screen, and the system will predict the physiological result all before you actually deploy anything and without any contrast.
Virtual stenting simulation based on physiology. Wow, okay, so we've used IVUS and physiology to guide the stenting. Now the stent is deployed. Traditionally, you'd do a final contrast injection, the beauty shot, to check it looks okay. How do you verify placement and expansion without that?
We use a few tricks. First, instead of relying on biplane X-ray systems, which aren't always available, we can use rotational fluoroscopy or cine radiology. You basically have the C-arm X-ray machine rotate around the patient while recording a short, contrast-free movie, a sine run.
Ah, so you get multiple angles quickly.
Exactly. You can assess the stent's position, make sure it looks well expanded, check for any pinching, all just by looking at the metallic structure of the stent itself from different views.
And there's software to help make the stent itself more visible.
Yes, stent enhancement technology. It uses image processing algorithms to make the metal struts of the stent stand out much more clearly against the background tissue. This is super helpful for checking things like ensuring good overlap if you're placing multiple stents, making sure the ends are landed in healthy vessel segments, and optimizing placement in complex situations like bifurcations. Even without specific software, just using a magnified view with a high frame rate can often give you a good enough look at the stent metal.
Okay. And finally, sizing.
Yeah.
If you're not using contrast puffs to gauge length or diameter, how do you do it?
We rely on device-derived length measurements. Think about it, the guide wires, the balloons, the IVUS catheters,
Yeah.
they all have tiny radiopaque markers on them at known fixed intervals, like every 5 or 10 millimeters.
Right, those little bands you see on the devices.
Exactly. Those markers act as a built-in ruler right there on the X-ray screen. You can directly compare the length of the lesion to those known markers on your wire or balloon to get a very accurate estimate of the length you need to treat. Same for diameter, using IVUS measurements. It completely removes the need for contrast just for sizing. So, a really key advantage here is that ULC PCI shifts the definition of success. It's no longer just about, does the final angiogram look pretty? Success is defined by objective numbers. Did we achieve an adequate minimum luminal area on IVUS? Did we normalize the FFR or NHPR across the treated segment?
Right, you have hard data targets. This must reduce the pressure to keep injecting contrast just to take another look.
It really does. Because often, the angiogram can be misleading anyway. A stent can look okay angiographically but still be underexpanded or have edge issues. The objective data from imaging and physiology is far more reliable.
Okay, but what if that objective data is suboptimal? Let's say the post-stent physiology measurement is still low, or the IVUS shows the stent isn't expanded enough? How do you figure out why and fix it without resorting to contrast?
That's where the power of the imaging really comes in. If the physiology is off, the IVUS or OCT pullback will tell you exactly what the problem is and where it is. Is there a dissection at the edge of the stent that needs covering? Is the stent itself significantly underexpanded in one segment? Is there still significant disease just beyond the stent that wasn't treated?
So the imaging diagnoses the problem.
Precisely. It characterizes the issue under expansion, edge dissection, residual plaque, and pinpoints its location. Then you know exactly what to do. Maybe use a higher pressure balloon to optimize expansion, or place an additional stent to cover a dissection, all guided by the imaging, without needing diagnostic contrast puffs.
Makes sense. Let's zoom out a bit. Complex cases often mean treating multiple blockages, maybe in different arteries, multi-vessel disease. Sticking to that CVA-GFR ratio below 1 might be tough in one sitting. Is staging the procedure, doing it in separate sessions, often part of the ULC PCI strategy?
Yes, absolutely. Outside of emergency situations like a heart attack, staging is often recommended, especially if you anticipate a long, complex procedure involving multiple vessels or challenging lesions like CTOs.
And the main reason is simply to manage the total contrast dose across procedures. Keep each one under that CVGFR limit.
Exactly. You do the diagnostic angiogram using minimal contrast, figure out the plan, then you bring the patient back for the intervention, again using ULC PCI techniques to keep that second contrast dose minimal. It allows you to tackle complex disease thoroughly without exceeding the safety threshold in any single procedure. It's contrast budgeting, essentially.
Okay, contrast budgeting. If you do stage it, how long do you need to wait between the diagnostic procedure and the staged PCI?
That timing is important. You need to wait long enough for two things to happen. One, for the body to clear the contrast from the first procedure. Two, and critically, to see if any CA-AKI is going to develop from that first dose, or to allow the kidneys to recover if there was a mild hit.
Right, you need to know the kidney function is stable before giving more contrast.
Precisely. So the minimum recommended interval is 72 hours. But ideally, the review suggests waiting at least 5 days. That 5-day window gives you a much clearer picture of the patient's renal status and ensures you're proceeding safely with the second stage.
72 hours minimum, 5 days ideal. Good clinical pearl. Okay, let's reiterate the specific types of patients or situations beyond just general CKD, where this ULC-PCI approach really shines, where it improves both safety and the quality of the job.
Yeah, the authors list several key scenarios. Chronic total occlusions, CTOs. As we said, these are often long, contrast-heavy procedures traditionally. ULC PCI tools like the metallic skeleton, IVUS, and DCR are game changers here. Patients in shock or after cardiac arrest, these individuals are incredibly unstable. Kidney function is often compromised or unknown. Minimizing contrast is absolutely mandatory. Severe left ventricular dysfunction, patients with very weak hearts who are very sensitive to fluid overload. The targeted hydration and minimal contrast are crucial. Coronary dissections, whether they happen spontaneously or during the procedure, iatrogenic. IVUS is far superior to contrast for seeing the dissection flap and guiding precise treatment, saving time and dye. Coronary dissections, any procedure where you anticipate it being long, like complex multivessel stenting. Just the duration itself drives up contrast risk. Coronary dissections, and obviously patients with a known contrast allergy. For them, zero contrast PCI guided by imaging and physiology is the only way.
That list really covers the sickest, most complex patients cardiologists face. The fact that ULC PCI offers a safer, better path for them is huge. And you mentioned this isn't just a collection of tricks, but the aim is a structured approach.
Yes, that's key. It's not meant to be improvised.
Yes.
The review emphasizes integrating these techniques into a structured, algorithmic framework. Think of it like a checklist or protocol, guiding the use of imaging, physiology, and contrast budgeting throughout the case. Figure 7 in the paper lays out a generic example. It provides a roadmap to ensure you're consistently applying these precision PCI principles.
Okay, we've laid out the compelling case for ULC PCI, the what and the how, but let's talk about adoption. The paper uses this great phrase that PCI has been inextricably linked to the angiogram, to the contrast image. Moving away from that must be a massive mental hurdle for operators trained for years, even decades, to trust what they see on that screen. How big is this challenge?
It's genuinely a radical shift, both cognitively and technically. Operators have spent their entire careers learning the nuances of interpreting those contrast shadows. Now they have to learn to trust different kinds of data, the grayscale cross-sections from IVUS, the pressure waveforms and numbers from physiology.
Trading the visual art for the quantitative science, in a way?
You could say that. It requires dedicated training, mentorship, and really a leap of faith initially to trust that the IVUS measurement is the vessel size, even if the angiogram looks different, or that the FFRNHPR number is the determinant of significance. And it's not just the physician. The whole cath lab team, the techs, the nurses, needs to adapt to new workflows, new ways of acquiring images, managing catheters, without constant contrast checks.
I can only imagine the learning curve, especially that moment when you don't do the contrast check you normally would have, and instead rely purely on the IVUS or pressure-wired data. Takes confidence.
It absolutely does. And that's why the authors stress a really important point about implementation. The goal isn't just to pull these techniques out for the occasional super high-risk case.
Ah, okay.
The real goal is to start integrating these ULC-PCI techniques into routine, everyday cases, even in patients with normal kidney function. Why? So that contrast hygiene becomes their normal practice mantra.
Ah, practice makes perfect. Use the skills routinely on simpler cases.
Exactly. So when that complex patient does come along, the one in shock, or with stage VCKD performing a sophisticated ULC-PCI procedure, isn't a stressful scramble. It's just doing what you do every day, efficiently and confidently, because the skills are deeply ingrained.
That's a really smart implementation strategy. Make it the default, not the exception. Now, let's clarify the end goal. Is the target always zero contrast PCI? Is any contrast injection seen as a failure?
No, and the authors are quite pragmatic about this. While the aim is ultra-low contrast, striving for absolute zero in every single case might not always be necessary or even wise.
Okay.
They actually recommend considering a final, very small angiographic injection, maybe using diluted contrast, at the very end of the procedure.
Why? After all that effort to avoid contrast?
For a couple of reasons. One, it provides psychological reassurance for the operator. It's a final check that there hasn't been some rare complication, like a tiny wire perforation distally, or maybe an unexpected side branch closure that wasn't obvious otherwise. Two, and this is important, it creates an angiographic record for the future. If that patient comes back years later, having that final picture can be really valuable context. So the philosophy is minimal, optimal contrast, used for safety and excellence, which isn't always strictly zero.
Pragmatic, minimize, don't necessarily eliminate entirely unless you have to. Okay, looking forward, where do they see this ULC-PCI approach going next? Where will it expand?
They expect it to become much more widespread, further solidifying the role of PCI, especially in those complex subsets like CTOs and bifurcations, where it offers clear advantages. Beyond that, they anticipate expansion into other areas,
Such
PCI and acute coronary syndromes, heart attacks. Currently, time is critical, but kidney function is often unknown or worsening. ULC-PCI could be huge there. Also, structural heart interventions. Think about TAVR transcatheter aortic valve replacement. Those procedures currently use quite a bit of contrast for sizing the aortic valve annulus and confirming the new valve position. There's definite potential for ULC-PCI principles there too.
Interesting. So basically, any complex procedure currently heavily reliant on dye for visualization could potentially benefit from this shift towards objective, measurement-based guidance.
That seems to be the trajectory. Ultimately, ULC-PCI is about elevating the standard of care. It allows us to offer high-quality, precise, and durable interventions to patients who, in the past, might have been considered too risky for PCI simply because of the contrast burden those with severe heart failure, end-stage kidney disease, unstable patients. It's a major step forward for both safety and technical quality.
It really sounds like it. A fantastic overview of moving from intuition to injective data in a critical field.
Yeah, I think to sum it up for everyone listening, ultra-low contrast PCI is really this fundamental shift. We're moving away from relying on subjective contrast images and towards objective precision guidance using tools like IVUS, physiology, and co-registration. The key is ensuring safety, primarily by keeping that contrast volume to eGFR ratio under 1 bond, while simultaneously achieving technical excellence for better, more durable results, especially for our most complex patients.
A shift driven by technology, enabling both better safety and better quality. That's powerful, and it leaves us with a final thought for you, the listener, to maybe ponder. If using non-contrast imaging and these quantitative physiological metrics can so profoundly change complex cardiac procedures for the better, where else in medicine may be areas relying heavily on CT scans with contrast or other procedures using lots of X-ray dye or radiation might a similar shift towards structured, objective, lower-impact guidance techniques completely redefine best practice in the future? Thank you for watching The Funnel Effect.